speakers and the panelists. And thank you, Seneca team, for this opportunity. So we all know that in the last 1 decade, we have seen wonders with targeted therapy, which almost pushed the borders from barely 1 year survival for stage 4 lung cancer to almost like 4 years now. And with available therapy, now the question remains the same: how to escalate the therapy, how to combine the therapies to get the best outcomes in some of the subgroups where even the survivals are very less, even with the advent of TKs. So I would like to call upon my speakers, Dr. Rohit Reddy, who's been talking about the evolution of NSCLC treatment with availability of so many new drugs in the market in the last 1 decade, and followed by Dr. Chennamaneni ma'am, who is talking about the role of NGS, and followed by Dr. Venkata Simha, who's be speaking about the intensification as well as the combination therapies approvals in the last 1 decade. So first of all, I'll start with Dr. Lohit. Can start your presentation.
Good evening, everyone. Thank you, Dr. Harish, sir, for this wonderful opportunity. Thank you, AstraZeneca. So today I'll basically start with a brief introduction on what has happened in lung cancer for the past few years. And in this particular talk, I will just
sir, we're
cover.
not able to see the slides, sir.
Right, I am just sharing that once again.
Yes, sir.
Right, can you see it right now? Is it okay?
Yes, sir.
Right. So we will just briefly go through the evolution of treatment paradigm in non-small cell lung cancer. Briefly, we'll touch upon the targeted therapies and how it has evolved over the particular years, the introduction of immunotherapy and how it has brought about change.
So the slides are not
Right.
moving. Yes, sir.
Yeah, the slides are moving. Okay.
Yes, sir.
So
Yes, sir.
this is the burden of lung cancer in India. According to the Globocon 22 data, lung cancer is the second most common cause of cancer found in males, and the average incidence is almost around 58,000 cases. It contributes to nearly 10% of the cancers in males. Even if we combine both the sexes, it's the fourth most commonest cancer, accounting for nearly 6% of all the cases. So this is how management has changed with time. In the beginning, we generally treated lung cancer as an entity, as a single entity. We just gave plain chemotherapy. Following that, we found out that there were two histologies, the small cell, non-small cell and the small cell. Further, it was broken down. The non-small cell was further divided into many other subsets. Now we have the various targeted molecules which are present, against which we have multiple targeted therapies. And apart from that, depending on the PD-L1 expression, we also see that there are two specific subsets, the ones who express more than 50% and less than 50%. Of course, TNB also plays an important role in starting these patients on immunotherapy. So now previously the only options were only chemotherapy and radiation, but now we have targeted and immunotherapy. And also we have seen combination of various other therapies. So this is a brief review which was published in 2020 in NEGM, and they have actually told that the lung cancer specific survival improved from 26% when men were diagnosed with non-small cell lung cancer in 2001. Currently, it was actually 35% in 2014, but right now if we see, it's almost to the tune of 45%. So the lung cancer specific survival has doubled within 2 decades. So that's attributed to the latest targeted and immunotherapies. So these are the two common paradigms that we use, the targeted and the immunotherapy. So this is how both in early and late stage non-small cell lung cancer, in traditional, they just only started with chemotherapy. Then initially crizotinib came, erlotinib for EGFR positive lung cancer, geftinib. Now we have arrived at an era where we are using a combination of both osimertinib with chemotherapy. We also have amivantamab for EGFR tumors. We have lorlatinib and alectinib for ALK positive tumors. Apart from that, we have selpercatinib for red positive and capmatinib, tepotinib for MET positive tumors. So this is how the targeted therapy has evolved. We are seeing more patients surviving even with limited side effects. And with the advent of immunotherapy, we have various options such as Nivo, Pembro, Durva, Atizo in lung cancer. So these are all at least the 7 molecular alterations which are FDA approved are EGFR, ALK cross. This is something which we all know. So this was the first actually wonder molecule, osimertinib, which has improved PFS as compared to geftinib or erlotinib in metastatic non-small cell lung cancer. This was the initial FLORA data, which was published in 2017, where it had shown a PFS benefit. The primary objective was a PFS benefit. And with this, there was the median PFS was almost to the tune of 18 months. And with ALK inhibitors, crizotinib, it was almost double. It was almost around 35 months. So alectinib following crizotinib, it improved overall survival over crizotinib. Now we have comparison of Crown trial, which compared lorlatinib versus crizotinib, and the survival data appears to be even more interesting. So these are other targets which are already existing. For MET, now we have capmatinib and tepotinib. For RET, we have selpercatinib. This is an old slide. For the HER2 mutations, definitely for at least 1 to 2% cases, we are using TDM1 molecule. Apart from this, there are other oral targeted anti-HER2 therapies which are coming. So this is one article which was recently published. This is zongertinib, which was used in previously treated HER2 mutant non-small cell lung cancer. It was just published 1 month ago. So this is one oral anti-HER2 treatment, which is actually showing some significance. So again, the traditional survival with platinum doublet was only 8 months, but now we are seeing an overall survival to the tune of 40 months. With recent advances, the survival has greatly improved. The osimertinib, which was previously used in metastatic setting, now has moved even to the adjuvant setting. The ADARA, it had shown survival benefit in adjuvant setting, whereas LAURA trial, we have seen that the survival improves even in stage 3 lung cancers post CTRT. Suppose you use osimertinib. In such a scenario, also there is a DFS benefit. So in ADARA trial, it was the osimertinib was used for 3 years, and definitely there was an absolute benefit in overall survival. Despite crossover, there was an absolute benefit of overall survival to the tune of 10% at 5 years. This is what, and the hazards, there was a 51% reduction in the risk of death with osimertinib. After the targeted therapy, we just go on to the immunotherapy. Immunotherapy, we have 2 major pathways. This is the CTLA4 pathway, and the other one being PD1 and PDL1 pathway. So the first molecule which came into existence was pembrolizumab. We all know that this is a wonder molecule, at least in the patients who have a PDL1 TPS more than 50%. There is a small finite subset of around 20 to 30% patients who continue to remain in remission beyond 2 years of immunotherapy. This was not heard before, at least in stage 4 lung cancers. You do not see patients surviving beyond 1 to 1.5 years with the traditional chemotherapy. So with the advent of immunotherapy, now we are seeing more and more patients surviving. Initially, it was only for the stage 4, but now even in stage 3, we have durvalumab post-CTRT unresectable lung cancers. We have perioperative immunotherapy, the Checkmate 816 and the Pembro trial. So again, with traditional treatment, the survival was only about 8 months to 12 months, but now with Pembro, it's almost doubled to the tune of 22 months, the average survival. So this is a keynote 24, a key trial which had shown that survival doubled nearly at 5 years as compared to chemotherapy alone, especially in this particular subset of PDL1 with TPS score of more than or equal to 50%. Again, we all know this specific trial where Durva 10 mg per kg given every 2 weekly, it improved almost 10. There was a 10% survival benefit at end of 6 years. At end of 5 years. So this the improvement in survival, the delta is almost around 15%. So now, as I've discussed, the immunotherapy is now actually entering into the adjuvant and neoadjuvant space. Especially, what is really interesting are these two particular trials, the Keynote 671 and Checkmate trial, where in the Checkmate trial, they've only just given 3 cycles of nivolumab, 360 mg. They have given in operable lung tumors between stage 1B, more than 4 centimeters, to stage 3A. And definitely, there is a very good DFS benefit. Even in the Keynote and AGN trial, they've used a common, like in the AGN, they've used Durval. In the Keynote trial, they've used Pembro. So following surgery, here the adjuvant was continued for a duration of 12 cycles. So these are key outcomes. The PAT-CR rate, as you see with chemotherapy, it's only 2 to 4%, which is standard across all the arms. But addition of immunotherapy, you see that the PAT-CR rates have almost increased to the tune of 20%. Now, it's not very clear in lung cancers as compared to breast cancer whether PAT-CR improves survival or not. But definitely, it's interesting to see that adding immunotherapy in such patients will help them. So these are the key EFS endpoints. Across all arms that you see that there is almost a delta difference of around 15 to 20% when you add immunotherapy in the perioperative setting. So what is new in non-small cell lung cancer? Just if you open the ASCO 2025 updates, you can see that there are multiple other things which are coming, like antibody drug conjugates. You have bispecific antibodies. You have some CAR T kind of therapy, cellular therapies, which are also being tried in lung cancer. Probably what we are discussing right now might be redundant in the next coming years. With this, I thank the organizers. I thank Dr. Harish and AstraZeneca team for giving me this opportunity.
Thanks, Rohit, for the wonderful presentation. It was very brief and you have touched upon most of the topics. And next, I'd like to request Rachana ma'am for the next topic, NGS in non-small cell lung cancer. And she'll explain about the role of NGS, whether it is comprehensive or hotspot. Thank you, ma'am. Thanks for being here.
Good evening, Harish. Thank you for this opportunity and thank you, AstraZeneca. I would be sharing my slides. Are my slides visible?
Yes, sir. Yes, ma'am.
In the presenter mode, right?
Yes, ma'am.
Okay. Okay. Yeah. So today we'll be discussing about the NGS in NSCLC. Dr. Rohit has already discussed about what's new in the NSCLC setting. So I'll be just briefly touching on the molecular diagnostics and the investigations which we need to do. Sorry for the disturbance. So the prevalence of molecular aberrations differs by histology in NSCLCs. Most oncogenic drivers are mutually exclusive. We know that EGFR, ALK and all, they don't coexist, but we do come across 1 to 3% of the patients where there may be a coexistent mutations like EGFR coming with ALK or ALK with MET, but those are rare instances. They're usually mutually exclusive. And if we see, the number of mutations are higher in the adenocarcinoma compared to the squamous cell carcinoma. 55% of the patients with adenocarcinoma have mutations. This is the worldwide data. But if we speak of the Asian or the Indian population, we have more higher incidence of mutations. EGFR mutations are almost seen in 40 to 50% of the patients in Indian subcontinent. So the driver mutation positive NSCLCs are higher in the Indian subcontinent compared to the Western population. In squamous cell carcinoma, most common mutations which are seen are the PIK3CA amplifications of the FGFR1 mutations, and accounting only for 34% of the patients with a mutation. And additional biomarkers which we need to evaluate are the PD1 and PDL1 expression and the TMB burdens. So initially, all the adenocarcinoma or the squamous cell carcinoma differentiation was mainly based on the histology. So, and then came the IHC of TTF1 napsin for the adenocarcinoma, P40, P63 for the squamous cell carcinoma. This was only differentials which we were using almost 10 years back. But later on, we started doing the tests, especially for the EGFR and ALK, which were the initial investigations which came up, followed by ROS1, MET, KRAS, BRAF, HER2, and RET, which we also have targeted therapies now. So the evolution of the biomarker testing, initially it was only tissue-based. So starting with the empirical therapy by clinicopathological factors based on the histopathological evidence. And now we have a tissue-based NGS or the multiplex testing, decision making, and where we can do both the DNA and RNA sequencing. Not only tissue, we can use the plasma-based, that is the liquid biopsy testing, which is going to be the future for comprehensive genomic profiling by NGS of plasma circulating tumor DNA, which would be very decision making and important. And I know most of the clinicians are also doing both the liquid and tissue biopsy upfront for adenocarcinomas in order not to miss out any biomarkers. So what is a good diagnostic test? We all know the qualities for a good diagnostic test. It should be accurate, it should be quick, simple, accessible, and it should be relatively cheap. And it should require only minimal amount of tissue. What is a mutation-specific test? What should be its characteristics? It should sufficiently cover the gene variants. It should be sensitive. It should yield clinically relevant results and should inform the treatment decisions. So coming on to the topic, that is next generation sequencing. And it allows for simultaneous sequencing of thousands to millions of nucleic acids. It is built on the first generation Sanger sequencing, but it is able to determine the sequence after each nucleic acid is incorporated, and it allows for simultaneous sequencing. Sanger sequencing had many limitations that we could do only limited number of sequencing, but NGS can do identify various number of mutations by simultaneous sequencing. The major steps involved in NGS are DNA extraction from the patient sample, fragmentation of the DNA, library preparation, sequencing, and bioinformatics and analysis. So, and there are different methods by which NGS is done using various platforms, various sequencing platforms. The most common methods which are used are either whole genome sequencing, whole exome sequencing, or targeted sequencing. In NSCLC, what most of us are doing is a targeted sequencing. Sometimes we do go for the whole genome or the whole exome sequencing, but most commonly we hear people discussing only about targeted sequencing, identifying those mutations which have a molecular target available. So identification of these predictive biomarkers has led to a paradigm shift in lung cancer diagnosis and treatment. Biomarker testing has been increasingly used to guide treatment decisions. So for the past 10 years and presently also, everyone is relying upon the diagnosis of the biomarkers, identifying the targetable biomarkers, and then acting upon it, both in the metastatic or the advanced stages and also coming up in the early stages. We do have in the adjuvant setting. And yes, we are going to get data in the new adjuvant setting also from this ASCO. And single gene testing, which was previously being done, is now being replaced by NGS, which is a multi-gene testing done simultaneously. So what did all this biomarker testing do? It led to so many approvals. You can see the crowding of all the drugs at the end of on the right side of the slide. Initially, we were only using chemotherapy and very few mutations were identified till 2007 or 2011. And after that, there are multiple targeted agents which are approved by the Just a second, sorry. So there are multiple targets or the multiple agents which have been approved by the FDA for various targets, starting with the ALK inhibitors or the RET inhibitors. Then we have the EGFR mutation inhibitors, and we also have various immunotherapy drugs which have been approved. So coming to the clinically actionable biomarkers in NSCLC, we have 12 gene panel, which is most commonly being done along with the PDL1 testing. And these 12 genes includes the EGFR, ALK, ROS, BRAF, KRAS, NTRK, HER2, MET, RET, and VEGF. We also do the PDL1 testing or the tumor mutation burden, that is the TMB testing, along with this 12 gene panel. So these are the guideline recommendations by the NCCN. Again, the same molecular testing for identifying these targetable mutations along with the PDL1 testing. And also, if we are doing a DNA-based NGS, we also have to see for the high level of the MET amplification, which is emerging as a new biomarker. So multiple genes are involved in NSCLC. So doing single gene reflex testing is usually a problem because of the tissue. We know most of the biopsies in the advanced settings are CT guided biopsy or a bronchoscopic guided biopsy, where we get a limited amount of tissue, which might not be sufficient to do a single gene reflex testing. So doing simultaneous testing of multiple genes by NGS would help us identifying all the targets which are there in a particular patient, rather than doing a single EGFR followed by ALK followed by other genes. So the patient-centered oncology is what is coming up, individualized patient treatment decisions, one test, multi-target, and what is the drug? Identifying the target and getting the drug, one patient evaluated by one test to identify the drug for that patient. So we are able to identify the companion therapeutic diagnostic test and the therapeutics, which will help us in planning a proper individualized treatment. So these are the characterization of the cancer genome, which was initially done by FISH, IHC, and now by the parallel sequencing. And coming to the Moore's law, which was there, initially the price of the genomic testing by the NGS was around $1 million when there was a whole genome sequencing was being done. Then slowly it has come down to $10,000 and $1,000. And now we know in India, we have it available for 8,000 rupees also, with the help of various companies, which are providing us some coupons to do the targeted testing of the genes, especially the 12 gene panels along with the PDL1 testing. So there are three key elements in NGS-based gene testing. One is sample collection, which is very important. Then doing the wet lab and the dry lab. The wet lab is the library preparation and sequencing, and dry lab is the NGS data analysis and result interpretation. So sample can be either the tumor tissue by the FFPE block or the blood, which is a liquid biopsy testing. And after that, we do tumor versus blood testing. We have the sample where we can do the DNA extraction, do the DNA analysis, and then analyzing the results. If it is a tissue, then we have to fix the tissue. First do the histopathological examination and selecting the tumor area, which is having the bulk of tumor cells, and then extracting the DNA from this tumor area and further analyzing with the NGS. Then the second step is the wet lab, where it is the preparation of the DNA, the library preparation, and then doing a sequencing. And this can be done by various platforms like the Illumina or the Thermo Fisher scientific testing. Then the dry lab, once the library preparation and sequencing is done, the data output is there. We have to align the sequences, identify the variants which are there, and based on that, we can do the sequence annotation and finally release the report. So sample collection, wet lab, and dry lab are the three important steps for the NGS. So this is the overview of the NGS, starting with the DNA fragmentation, library preparation, enrichment, then the limited PCR, followed by the paired and next generation sequencing, alignment, and binary file making. So after all these things, we do a report generation, tied to informatics, and then the report generation. So what are the advantages of NGS? It is highly sensitive. It is able to interrogate comprehensive panels of clinically relevant genes. It is capable of detecting single mutations, gene rearrangements, and copy number alterations. Turnaround time, 1 week to few weeks. We are also getting some labs saying that they would be doing within 3 to 4 days also, but I have no experience with that labs. Maybe some of you might be doing it. So if we get the results faster, then it's very easy for us to plan the treatment for NSCLC patients, usually who are very, very symptomatic at the time of presentation. But what are the disadvantages of NGS? It can be time consuming depending on the size of the genomic regions which are captured. It is expensive still. If you want to do the whole genome sequencing, then it is expensive unless you have some support from companies and all. If not, you do have tests which go up to 2 to 3 lakhs also for the NGS. It requires more DNA and more tissue also. And sometimes it may miss some alterations such as the metaxon 14 mutations. So the biomarkers which are detected, we can detect point mutations, we can detect metaxon skipping, we can detect gene rearrangements like ALK and ROS, we can detect copy number variations. So various NGS tests have been FDA approved as a companion diagnostic test, and the validation process for NGS assess in the clinical setting is highly thorough. So Sanger sequencing, which was what I was telling you, based on which the next generation sequencing has grown up. And we have the gold standard. It was the gold standard for Sanger sequencing, high accuracy and longer turnaround time. But with the next generation sequencing, there is very much improvement in the accuracy, shorter turnaround time, but it requires complex bioinformatic algorithms and has high potential to detect the genes or the mutations. So this is a more broader mapping of the NGS process of how the quality control is done, where the quality control is being done. The test is passing that, how do they retrieve the DNAs, how do they sequence it, prepare the library, and further do the processing. So to conclude, biomarker testing has evolved from a single gene to multiplex testing. New methods such as next generation sequencing shows immense promise for the future. It helps in multiplexing key actionable genes for a cost-effective, accurate, and sensitive assay. Targeted cancer panel are useful for drug repurposing of small molecule inhibitors. Pre-analytical issues are major concerns. So multidisciplinary meetings along with the geneticists should be involved to identify the targetable mutations in cases which we don't have a direct actionable mutation. So thank you.
Thank you so much, ma'am, for such a detailed review on NGS. And one question, ma'am. Hello.
Yes.
Yeah.
Harish.
Do you suggest RNA sequencing upfront? You're doing, ma'am, currently in your
Uh,
practice?
no, in my practice, I'm not doing NGS also for few of the patients. We are only still sticking up to some FISH and PCR based techniques also for few of the patients.
In-house. Yeah.
Yes, in-house it is available. We have a diamond project from the ICMR which is doing free of cost for the patients. EGFR by PCR and ALK ROS by FISH testing, IHC and FISH. So this is available in-house. So, but whatever we are able to send a few number of patients, we are able to do NGS by the DNA analysis only. But if given an option, I would ask for both DNA and RNA.
Okay.
So I'm not doing it, but I would suggest that it's better to do
To be
both
done
DNA and
for
RNA.
developers.
Yes.
Got it. Yeah. Thank you, ma'am.
Okay.
Thank you so much,
Harish.
ma'am. Yeah.
Yeah.
Next, I invite my next speaker, Dr. Venkata Simha, sir. I'll be talking about escalation, basically combination of chemotherapy along with the targeted therapy. And over to you, sir.
Hello.
Yeah. Can you hear me?
Yes, sir.
Yeah. Hello. Hi. Good evening to all. How are you, Harish?
Yeah, you
Am I
can take
audible?
over, sir. Yeah, I'm good. Can
Yeah. So at the outside, I thank these people for providing this opportunity. So can you please start the slides? Yeah. It is in presenter mode now.
Yes, sir.
Yeah. So my topic is for today is synergizing the targeted therapy TKA combinations with chemotherapy in NSCLC. Next slide. Next slide. Yeah. The overview is, first of all, the first thing is biomarker testing. So that is made easy by Rachana madam previously, and the survival patterns over time with the use of TKIs, and the rationale why we are combining TKA and chemotherapies, and what are the TKA plus chemotherapy combination trials so far, and TKA plus VEGF inhibitor trials, and TKA plus EGFR antibody trials. So next slide. As you know, NSCLC is no longer a single disease. So morphologically, it is a squamous adenocarcinomas, and genomic wise, it is a number of diseases based upon these genetic mutations like EGFR, ALK, RAS, red MET, and so on. So next slide. Yeah, the same thing. The single gene testing is somewhat time consuming, but our because most of the people, but still offer this thing. We are offering like this only because most of the Arogyastri patients, they will go for like this, like as Rachana madam told previously. So we are doing step by step. But some people, we are using this type of multigenal panels, that NGS, which is not time consuming and helping in fast decision making about the management of the patients. Next slide. So this the same thing only. So single gene testing and multi-gene panels with PDL1 assessment. So if at all any driver target the mutation, that is the targeted therapy, and if it is not, means the non-targeted therapies like immune checkpoint inhibition. Next slide. Yeah. So once the disease progression, if the patient is already on TKIs, if at all the disease is progressed, means then definitely we have to go for this mutational testing. That is, if at all previously patient uses the EGFR TKS first generation, second generation TKS, we can go for EGFR T70M mutation analysis by liquid biopsy, that is ctDNA, or from the tumor blocks. Or if at all patient is using already on a third generation TKI, osimertinib, means we are directly going for NGS panel from like both liquid biopsy and or from tumor tissue. If the patient is on other non-targeted therapies like ALK, RAS, MET, RET, all those things also, if at all disease is progressive, means we have to further ask for this type of multi-gene testing on progression on liquid biopsy and or tumor blocks. So if the patient is not on any targeted therapies, non-targeted therapies, whether it is an immunotherapy, if they have done multi-gene panel upfront only, there is no need for asking again this mutational testing at the time of progression. Next slide. Yeah, these are the survival patterns. Hope the slide is very busy and it is very narrow. Hope everybody is seeing this slide, so that we move forward from simple chemotherapy doublet, that is platinum doublet, from the 4 months or 8 months, 4 months in squamous and 8 months in adeno, to place where using the platinum doublet with bevacizumab, where the survivals are increased up to 12 months. If at all, if you're using the maintenance also, pemetrexed maintenance, it will go up to the 14 months. And now the era is this targeted therapy and the immunotherapy. With the targeted therapy, the survivals in the stage 4 lung NSCLC will go up to 39 months. With the osimertinib and alectinib, it is somewhat 35 months. And still the definite thing is not reached. Like that, only in the RET, if at all RET driver mutation is identified, means there are some other drugs with selpertinib and pralasetinib. So those things also, survival still not yet reached. In NTRK, like that, only RAS and BRAF and MET exon mutations, the survival was significantly improved with this targeted therapies compared to the chemotherapy doublets. Next slide. Yeah, this is based upon the EGFR mutation in first line NSCLC. When we use the first generation TKIs, that is ipasaretinib, that is, and median PFS is 9.5 months, whereas in optimal trial with erlotinib, it is of 13.1 months, and it is almost 11 months with Luxelang trial with use of afatinib, and tacamatinib, it is 14.7, and this osimertinib, it is almost 35 months. So 18.9 months is the median PFS. Next slide. So as you know, once the survival is improved, means we have to go for still more improvement in the survival rates. For that only the combination strategies we are using. So there are three combinations we can use to improve the survival rates. One is that EGFR TK inhibitors plus VEGF inhibitors, or EGFR TKS plus EGFR antibodies, and most commonly that is EGFR TKS plus cytotoxic chemotherapy. Next slide. Yeah, the rationale is here is the chemotherapy and this TKS, the targeted therapies, is basically this TKS make the chemotherapy more effective in the form of they improve the sensitivity of these cancer cells to the chemotherapy, cytotoxic chemotherapy. At the same time, they delay the chemotherapy resistance. So next slide. So pemetrexed first line. So here the patients are we are using like in one arm we are using only geftinib 250 mg, whereas the other arm they are using geftinib plus pemetrexed carboplatin with the maintenance pemetrexed, and the primary endpoint being the PFS and second endpoints being the OS and safety profiles. So the here inclusion criteria based upon the first line EGFR mutated NSCLCs, and stratification was done by EGFR mutations exon 19 versus exon 18 or 20 mutations and performance status wise. So next slide. Yeah, he clearly the graph shown that median PFS is almost 16 months in the combination group, that is Jeftinib plus chemotherapy, whereas with only Jeftinib it is of 8 months. The overall survival is not reached, whereas in Jeftinib it is of 17 months with 95% confidence intervals with good hazard ratio of 0.51 and 0.45 respectively. Next slide. And the results are hold good for all these stratified subgroups, that is exon 19 versus others, and even the brain mets also. So which also favors Jeftinib plus Pemcarbo. Next slide. So this is another trial that is NEJ009 trial. This also same thing. So here there in the TMH study, they used only pemetrexed in the maintenance in the Jeftinib plus chemotherapy arm. Here, they stratified Jeftinib on one side, and another thing in the maintenance also they used Jeftinib plus pemetrexed. Initially, induction is also with Jeftinib, pemetrexed, and carboplatin. The endpoints will be the PFS, and the secondary endpoints will be the response rates and safety profiles. Next slide. Yeah, here also the PFS is favors the Jeftinib plus chemotherapy and maintenance also with chemotherapy and Jeftinib arm, and even OS is also favoring towards this combination targeted therapy plus chemotherapy with good hazard ratios and at 95% confidence intervals. Next slide. So even subgroup analysis also holds good. That is, brain mets at the time of screening, even with liver mets, and easier for mutation 19 or L858 or mutations also. Survival rates and response rates compared to only targeted therapy with Jeftinib. Next slide. These are the other phase 2 and phase 3 trials where they used whether it is with the concurrent or sequentially as a maintenance rates are better with a combination of TKI with the chemotherapy. Next slide. Next slide, please. This is also busy schedule. Hope you are seeing the there are also, if at all patients in that one, this ESMO guidelines, they showed that if at all the patient is not affordable for osimertinib, it is better to start with first generation and second generation TKIs with the combination of chemotherapy. Now, next slide. Hello. Slide is not visible to me. Yeah, this is again trial where they use this osimertinib and Jeftinib on one side, and other side they are using the Jeftinib plus osimertinib with chemotherapy and osimertinib with chemotherapy. Here in this again trial, they included this recurrent cases also. These in this trial also the survival rates and even the response rates are good with Jeftinib versus Jeftinib plus chemotherapy and even osimertinib plus chemotherapy. So osimertinib plus chemotherapy and Jeftinib plus chemotherapy is better when compared to the Jeftinib and osimertinib single agents. Then next slide. The same thing only what I told, the PFS and all those things. So this is another in the Opal study. So this is also the first line. The previous slide, please. This is also the basically the only osimertinib. In again trial, they use both gefitinib and osimertinib, and they compared with the combination of chemotherapies in first line and second line setting. Whereas in Bhopal study, here this is also non-squamous first line NSCLCs, where the osimertinib plus cisplatin plus pemetrexed was in one side, and another one that is osimertinib carboplatin plus pemetrexed. So maintenance with osimertinib plus pemetrexed. So this also the PFSs and OS are better with the combination of chemotherapy plus this targeted therapy, that is osimertinib plus cisplatin or carboplatin plus pemetrexed. Next slide. So this FLARA-2 trial, this is one of the important trial and landmark trial. So the most of the patients EGFR will progress following a treatment. So the factors being the CNS metastasis or L858 mutations. So osimertinib, a third generation CNS, it is CNS active EGFR TKI, is the preferred first line treatment for EGFR mutated advanced NSCLC. Clinical data on first generation TKIs combined with chemotherapy have suggested enhanced efficacy. So osimertinib plus platinum pemetrexed recently showed encouraging two. This is a back the FLARA-2 trial that is a Opal it's not showing properly. This is a FLARA-2 trial design basically. So this pathologically confirmed. Previous slide, please. Hello. Hello.
Yes,
Previous
sir.
slide. Previous slide. Yeah. See here the FLARA-2 phase 3 study design is that this first line setting in pathologically confirmed non-squamous NSCLCs. So with risk stratification based upon the Chinese Asian, non-Chinese Asian, non-Asian, and EGFR mutated also local central test, and based upon the performance status. Here the arms will be the mainly the osimertinib as a single agent, and osimertinib with the combination of platinum doublet and maintenance with again osimertinib with pemetrexed. So the primary endpoint will be the PFS, and the secondary endpoints with the overall survival rates and the response rates. Next slide. Yeah, and when you clearly here is only with 16.7, whereas with the platinum doublet is of 25.5 months. So next slide. So here the progression-free survival for BACR, median POS was improved as 9.5 months with osimertinib plus platinum doublet versus osimertinib monotherapy, that is 19.9 versus 29.4 months with good hazard ratios with significant p-value. Next slide. In this stratified subgroups also, that EGFR mutations, that L858 mutations and exon 19 deletions, and even CNS mets also, all these things, this scores good with osimertinib plus platinum doublet. Next slide. So even that median best percentage change of CNS targetable lesion is also better with osimertinib plus platinum doublet compared to osimertinib monotherapy. So that the complete response rates also, when in the down, if you see the complete response rates, it is of 45% in case of osimertinib monotherapy, whereas in case of combination therapy, it is almost 70%. So there is a significant median best percentage. Next slide. So the same thing based upon the EGFR exon 19 deletion versus exon L858R mutations. In this also, the combination of osimertinib plus platinum doublet having better PFS when compared to as osimertinib as monotherapy. Next slide. So the other thing is this TKI plus VEGF inhibitors. Next. So as you know, these are the first generation, second generation, third generation TKS, and this other EGFR antibodies, you know, that is amivantamab and necitumab. The other thing is here the VEGF targeted agents like bevacizumab and ramucirumab. So that TKS like nintedanib and axitinib and selutinib, which target the receptors, that is especially the VEGFR2. So next slide. So these are the various trials. I don't think so anybody using like this erlotinib plus bevacizumab or in the routine day-to-day practice. So these are the few trials in phase 2 and phase 3 trials, that a combination of bevacizumab plus erlotinib, and there is a combination of bevacizumab plus osimertinib also compared to single agent like erlotinib. These are the some of the studies and their PFS and overall survival rates. Next slide. So this is again the summary of TKS plus VEGF inhibitors. Next slide. So like moving on to the most important thing, that is TKA plus EGFR antibodies that you know that recently that amivantamab plus lazertinib. Next. Yeah. So lazertinib is a bit activations like EGF, NTM, and CNS disease. So preclinical studies demonstrate improved antitumor activity when both extracellular and catalytic EGFR domains are simultaneously targeted by amivantamab and lazertinib. As you know, EGFR amivantamab target cellular domain, whereas lazertinib is the intracellular domain of the EGFR receptor targeted by this lazertinib. So the study is that TKI plus EGFR antibody Mariposa trial design. This is the first with documented EGFR mutations like EGFR exon 19 deletion or L858R mutations. Previous slide, please. Previous slide. Yeah, the trial design is that amivantamab plus lazertinib in one arm and osimertinib in another arm. Next slide, next slide. And lazertinib in another arm. So the endpoints will be the basically the progression-free survival rates, and secondary endpoints will be the overall survival rates and the safety profiles. Next slide. Very clearly, I think it is not visible. properly. See, clearly the median follow-up of 22 months, median PFS with amivantamab plus lazertinib is 23.7 when compared to osimertinib, that is of 16.6 months. With only single agent lazertinib, it is of 18.5 months, which was seen in all subgroup analysis. EGFR mutations and history of in smoke. Next slide. Yeah. If you go for possible first line treatment options with the use of, if you follow the FLARA osimertinib, so first line the median PFS is 18.9 months. So if at all, if that patient is progressed, it means in the second line the options will be the pemcarbo or amivantinib plus lazertinib with median PFS of 5.1 month in case of amivantinib and lazertinib when you use the drugs, compared to chemotherapy, which is of only 4.2 months. So if you use that osimertinib plus combination of chemotherapy, so in case of first line, the options in the second line will be the only the amivantamab and lazertinib. So in if you use amivantamab and lazertinib as a first line drugs, so the options in the second line will be the only pemcarbo, only chemotherapy. When you go for Mariposa 2 trial, the patients who are progressed on osimertinib, the options will be either carboplatin plus pemetrexed plus amivantamab plus lazertinib, or single agent amivantamab plus carboplatin and pemetrexed. So the survival rates are here. Clearly, the first line in osimertinib median PFS is of 18.9 months. If you use combination of chemotherapy with osimertinib, the PFS is improved almost 8.5 to 9 months. It is of 25 to 25.5 months is the median PFS. If the same thing with the Mariposa trial, it is of median PFS is 23.7 months. So the side effects, this with the use of combination of chemotherapy, little bit increase in the neutropenias and diarrheas will be there, and especially with amivantamab, the rash and paranoias and some of the hematological reactions are common that need to take care, and basically the infusion reactions are more common with amivantamab. So little bit as an induction. So next slide. So this is NCCN guidelines that if at all EGFR mutation is positive, both osimertinib with the combination of chemotherapy or osimertinib also. So the both are category 1 recommendations only. So next slide. To conclude, newer TKS plus chemotherapy offer a new first-line treatment option for patients with EGFR mutated advanced NSCLC. TKS in combination with other therapies like VEGF or EGFR antibody look promising for patients with EGFR mutated NSCLC. Of course, the right patient selection is vital. The toxicity profile we need to manage. Next slide. Thank you.
Thanks, Venkat, for such a lucid review. And from now, we can go to the next session. For the panel discussion, I would like to invite my panelist, Dr. Supreet from Sri Shankara Cancer Hospital, Bangalore, Dr. Sandeep from SCC Cancer Center, Bangalore, Dr. Kishore Chandra, Renova BB Cancer Hospital, Hyderabad, and Dr. Minu Chandra from Guntur, Dr. Hanisha Polavarapu, Humay Hospital, Guntur, and Dr. Mahanti from Kim's Hospitals, Guntur, and Dr. Sreekanth from SC Cancer Center, Visakhapatnam. Yeah. Can you share the... Let me share once. Let me try. Can you see the slides?
Yes, it is visible.
Yeah, okay. So thank you so much, everyone, for being here. And it's my privilege to moderate this session. And I'm Dr. Harish, Concerned Medical Oncologist at Hyderabad. So
Sir, if you
briefly,
could
as a
try putting the slides into presentation mode, sir, if possible.
let me check once. Okay.
Yes, sir.
Background text. Mm, I'm not able to do this. Sorry. So I'll go this way. Don't no problem. Okay.
Okay, sir.
Yeah. So as our previous speakers discussed about the role of NGS and the molecular subtyping and the role of the new drugs in combination with the TKAs and chemotherapy combinations which evolved over time and helped in the survival outcomes. We all know that it is a long journey for in the case of lung cancer patients who have at a one point of time it is to be like we have to treat with only chemotherapy and now just a second, sorry. Now the recent trends that we can check for the several mutation patterns and we can based on that we can take up the patients for precision oncology drugs like MAPS and NIPS. So it all depends on the right variety of the patients we can test for and we can check up on the mutations accordingly we can guide for them. So I would like to request panelists to say their experience. How many of are doing NGS upfront for all of our patients? Shall I start with Dr. Supreet? You do NGS for every of all the lung cancer patient that you're setting, or still some patients are not affordable, so that you are still trying to get away with the ISC or FISH or PCR methods?
No, sir. I would try to do NGS for almost all of the patients because with the advent of coupons and limited in panels, at least most of 98, 99% of our patients would be able to afford NGS. At least the select targetable mutations I would do.
Okay. So do you do like both DNA RNA sequencing or
Yeah, sir. Yeah. I would do DNA RNA because we should not be missing out on fusions, which are also important.
Okay. Dr. Kishore, what about you?
Yeah, I am doing almost NGS in 80% of the patients.
Okay.
At least a few 20% only I am doing EGFR across individual.
So I think based on the institution, most of us are doing the like targeted hotspot or competency method NGS
Yes.
for our patients. So that's the way to go. We, as all our guidelines and previous speaker mentioned, that whenever there is the right patient like adenocarcinoma, never smoker, and who has a metastatic disease or even now in early stages, will suggest molecular testings to check for these mutations, where we always we can customize the treatment options for them with availability of so many drugs in the market. Whenever we don't get any mutations, obviously we'll reflex we do the PD-L1 testing parallelly, which will help us stratify the patient based on that PD-L1 percentage. We can advise the type of immunotherapy based on the affordability, and we can combine or we can give as a single agent based on the PD-L1 percentage. So let's take the case file where the 60-year-old female, where she's a non-smoker, being without any comorbidities and with the ECOG performance status of 1, and has presented with the hemoptysis history of for 1 month on and off. She was evaluated and CT was showing instantly detected upper lobe lesion with the multiple lung lesions. And from this point, what are the further tests would like to do in this patient who has present the hemoptysis to you directly. Dr. Mahandi?
Yeah. So the next I would be doing is to plan for a biopsy and PET CT scan.
So what if he has a suprachiasmatic lymph node of 2 centimeters? So which
Yeah.
biopsy you would like to do?
Excision biopsy of the cervical lymph node.
You want excision or you would like to do a core biopsy?
Ideally excision, if we can do under local, because that would give me good tissue. Core biopsies, as we already know, tissue is always the issue. So if the core is not good, that's another problem.
Okay, okay. So how many gene panels do you usually do?
Yeah, most often it turns out in our setting, it will be either 9 or 12 gene. Most of the time we do the coupon panels. So that will be hotspot only.
Okay. So Dr. Sandeep, so we need MRI in this case, MRI brain.
Yeah. Hello. This is
I think,
actually
yeah.
non-smoker female. Based on the histology wise, actually guidelines tell to do MRI. But practically, I don't do MRI for this case. Based on histology, if it goes to fairing small or adeno or small cell, I would like prefer to do MRI. Otherwise, based on symptoms, I'll do MRI. Brain.
Okay. Dr. Supreet, what about you? Do you MRI in each and every case of stage 4 NSCLC or only specific histology as doctor mentioned?
No, if it is small cell lung cancer, I would do for everybody. For non-small cell, only if the patient is symptomatic and it is anything less than stage 4, I would do.
Any other panels differ or concur the same?
Yes,
Any
sir.
other panels have different opinion on this?
No, sir. Like we also follow
No,
the
sir.
same thing. So based on the histology, probably I would take a call.
Okay.
The guidelines actually tells even at the stage 3 of NSCLC, we should do.
MRI brain, I know, like my personal opinion should do for every patient because we are using these third generation drugs where we response assessment done in terms of intracranial activity. So MRI we should include for each and every patient, which will help us whether they're having any ICR response or not, and follow will come to know. Most of if you use the first line, they'll progress in the CNS, and osimertinib or if you use alectinib or relatinib intracranial response is one of the endpoints. So in my practice, I've started doing MRI brain, and I of course the recent guidelines also included brain imaging because we all know that PET CT is not so sensitive for the brain part.
I agree, sir. The issue is more to do with the logistics because in lung cancer, as you know, the evaluation itself takes a long time. And the MRI brain would add to another investigation, and it says that the patient should not be lost to follow-up, being irritated by so many tests. That is the only reason. Otherwise, I guess, yeah, as you suggested.
Yeah, we talk about the only guidelines and what like I know understand that part. So yeah, but just I want to make clear that the drugs are have so many drugs like intracranial response that's the ideal way to go. No problem. So we generally do PET scans for everyone. Hello, Kishore?
This for
Or
me, sir.
Yes,
yeah.
sir. Yes, sir.
So we are
We
doing
are
PET
doing
CTs for everyone.
PET scan for everyone.
Good. So for this case, we did the PET CT scan, where similar findings as confirmed in the CT scan, like large Apollo mass along with the right supercal lymph node as well as the mediastinal nodes. And there was MRI brain also revealed multiple enhancing hemorrhagic and non-hemorrhagic lesions in the brain with mild edema of some of the lesions. And we did the NGS 12 gene panel where she was found to be having L858 or EGFR positive mutation. So in this case, one by one can answer. We'll start with Mahadi. What is your first line of option? Like, what is standard of care at United State or anything you would like to add? What are the options?
So we have a targetable mutation. Then I would go for osimertinib plus chemotherapy. And we do have brain lesions, but the patient is asymptomatic and I have a targetable lesion, then I will wait out for the whole brain radiation part. We'll continue with
There
the
are
system.
multiple and hemorrhagic.
Yeah, the size is also, I mean, the size and the symptoms matter. If they are asymptomatic and smaller size, I've seen good responses. 2 to 5 lesions, multiple lesions, they almost disappear with targeted therapies. So the size and these also matter.
What size you take in terms of when we take for a call for SRS or WBRT? What size criteria you follow?
SRS will be less than 3 centimeters, single lesion, or multiple lesions, then combined should be 2 or 3 lesions, and combined should be less than 5 centimeters for SRS.
Okay. Dr. Sambat? Supreet, sorry. Dr. Supreet?
Yeah, yes.
So what is your first line of choice in this case?
So in this case, I would go with chemotherapy plus osimertinib because of two reasons. One is L858R and brain metastasis.
Yeah. So anybody's up for other options like osimertinib alone or amivantamab or erlotinib plus ramu? All are with osimertinib plus chemo?
Yes, sir. Osimertinib plus chemo.
Okay.
Yes, so Dr. Sreekanth here. So most of the times I would like to add if a patient present with symptomatic brain metastasis. So by the time what happens practically is by the time we get the NGS report, so we would have at least 1 to 2 weeks of time. So if the patient is symptomatic, most of the times we do tend to start palliative radiation by the time. So or sometimes if the patient is not symptomatic, so we are pushing for 1 cycle of chemotherapy first. So that's what we are doing actually in practice, like for those patients like with good significant disease burden.
Yeah, I agree. So while waiting for the results, if there are multiple and more than 2 centimeter or causing edema, so sometimes patient may not report mild headaches and all. So even the treatment will take some at least 6 weeks of median duration of response for anyone, like alone or with combination of chemo. But yeah, if there are multiple and involving critical areas, better to irradiate before taking further therapy. So this Flora 2 design, which was discussed earlier, it's basically open label and multicentric study where they've included both only these common mutations, excluded uncommon mutations, and given combination of osimertinib chemo for 4 cycles followed by prem maintenance versus they've compared with the osimertinib alone. And in this, the progression survival was remarkable and the longest ever we achieved, like it close to 25 months versus 16 months. And we can see that delta of 9 months and almost like at end of 2 years, around 60% versus 40% overall PFS benefit was shown. And it's being open label, I'll always confirm with the blinded independent review as well. So which also concorded with the results, like more than 90% concordance with all the patient related outcomes with the combination of showing up to 29 months of PFS versus 19 months with osimertinib monotherapy. So if you look at the subgroup stability as well, also cleared where we can see the benefit across all the subgroups, and that is really help us in deciding which patient subgroups are more benefited in combination, or we can give alone osimertinib as well as. And one more, the same thing has shown in the OS as well. So Kishore, currently, how are you managing this brain metastasis in your case? Suppose this patient's having more than 2 centimeter or symptomatic, so and only 2 lesions. What kind of radiation would like to suggest for this lady, and before taking up for chemotherapy slash chemo plus osimertinib?
Actually, if there is only 2 lesions amenable for if SRS less than 3 centimeters, we can go for SRS. If they are multiple, then we would go for a whole brain RT.
Okay. So
If asymptomatic patients, I would like to go with osimertinib plus chemotherapy if they are multiple also.
okay. So anybody here add
Actually, for SRS and SBRT, there should be oligomets only in brain. There should be mets. If it is a mets anywhere else other than brain, again we should go with the whole brain RT, even if it is a 1 or 2 mets in the brain.
Okay. Fine. So this combination we are advocating for each and every subgroup, or there are any subgroups still you want to consider we can avoid. Dr. Hanisha?
For all the patients who are able to tolerate, depending on the performance status, if they're okay, then I would prefer combination in all EGFR positive metastatic NSCLCs.
Which subgroups would like to avoid?
Even in patients with brain mets and bulky disease, if the performance status is good, then I would definitely prefer a combination therapy.
Okay, for a 76-year-old?
No, not for the 76-year-old. If yeah, but less than 60, 65-year-old, the patient has got good performance
Yeah, I'm just
status.
would like to make a point which
Mm.
other which kind of patients practice would like to avoid the combination.
Yeah,
Dr. Suprit?
elderly patients who I feel that bone marrow suppression is mainly hematological toxicities that are seen with the combination therapy. So I'd like to avoid in elderly population. Yeah.
Good. Dr. Suprit?
Yeah. I agree with Dr. Hanisha. Elderly, frail individuals, exon 19 deletion, low disease burden, and patient's preference. These are the factors which would decide.
Okay, got it. Yeah. So same thing has been shown. Those patients who had a CNS metastasis and the delta, the like kind of improvement in PFS was huge, like 25 months versus 13.8 months in those patients who have CNS metastasis, and those without CNS metastasis, like the usual, like they're still significant, but the the ranges are wide, like 27 versus 21 months with the single agent osimertinib. And as Dr. Venkat mentioned, the complete response is also huge, like around 40% in those patients who received combination. And at the end of 2 years, 9% were there's a relapse free from the CNS point of view, compared to 23% with the single agent osimertinib. So the combination has the better intracranial response as well as maintenance and preventing the further relapses. So bulky disease and CNS metastasis definitely we with this regimen. L and who are ECOG 2 or 3, and those patients who are cisplatin ineligible or carboplatin ineligible. So, do you have, Dr. Minchandra, do you have any preference for this mutation? Like these study completely included only those mutations, like common mutations, L858R and exon 19 deletion. They have excluded exon 20. So, you have any preference when you see these mutations on your report, Dr. Minichandra? Is not there? Dr. Sreekanth?
Yes, sir. So with the advent of third generation EGFR TKIs, so I don't think we would treat differently. So previously, when we used to use first and second generation TKIs, probably considering L858R as a poor response compared to exon 19. So at that point of time, there used to be a practice change, but with third generation, I don't think we are changing anything.
Yeah, I agree. So that same results were shown, but in the subgroup, though I cannot say it as a remarkable difference, but in those patients who have exon 19 deletion, the difference was less, like around 8 months, and those with L58R, there is a huge difference, like 24 versus 14 months. That is as if we seen in the CNS metastasis, because L58R even in the Flora also the survival was lesser with this kind of mutation. So if you see at this mutation, we can definitely consider combination chemotherapy without any doubt. So what about the safety profile in your practice? If you how many patients have used this combination so far, Dr. Sandeep?
I have one patient who I initially started with the chemotherapy, later added the osimertinib.
Okay.
That after 2 cycles, we started adding osimertinib to that patient. At the time, they tolerated very well. The side effect profile is similar to a chemotherapy, that PEM carbo chemotherapy. What side effect were there? Like a neutropenia, and
Okay.
there's a chemotherapy side effect, and they are manageable.
Manageable. Okay. Dr. Mahdi, how many patients so far tried on combination?
As of now, none on combination.
Okay. So next, Dr. Sreekanth, Dr. Sandeep, your experience?
Yes, so since over the last 1 year after the phase 2 data was out, so I was pushing for this combination. So I could give up to, I think, 4 patients who are on this combination. So safety wise, like nothing unexpected apart from the usual hematotoxicity. So toxicity, but that could be due to chemotherapy also. But most of them need not. I mean, during the initial chemotherapy phase, the dose delays were actually not that significant. So I was pretty comfortable in the patients in whom I have started this combination.
Okay. Anybody of you already used a TMH protocol, like where we have used first generation TKs with chemotherapy? Anybody has some experience on the first line
I have
TK?
used in a lot of patients. It is pretty well tolerated. But it's just that during later phases, patients get more and more toxicities due to pemetrexed, renal dysfunction, and etc. But apart from that, it's usually well tolerated. And that is kind of the go-to regimen for me.
Yeah, so that will always save a lot of cost. So cost is proprietary. We can definitely use simple chemotherapy along with the JEF or LO in our setup. But yeah, whenever affordable patients are there, it is always best to use the best drug upfront. So yeah, the safety concerns are definitely will be there, especially when you're adding the combination of PK and chemo. So that most of the chemotherapy side effects are like hematological. Almost in this combination of there were reported like 64 versus and 27%. Most of them hematological and related to the chemotherapy, fatigue and loss of appetite and neutropenia, anemia. So they're all pretty manageable already. We have been using for the chemotherapy part for many patients, and as along with the first line TKs as well. So that has to be a concern of for only those patients who have a kidney dysfunction upfront or elderly frail patients who have performance status like 2 or 3. Those patients definitely be cautious while before starting combination, so that we can go slow in them. Maybe start with osimertinib and slowly we can see the similar responses without affecting the OS. So this the current patient got an assessment after 4 cycles and achieved partial response and complete response in the brain. And another the response was maintained for 11 months and repeat PET CT after 11 months, showing similar static lesion. So still on continued response with the combination therapy. So it has showed consistent benefits across the pre-specified subgroups. And what is your next line of treatment once you're done with the this combination? If somebody
Hello.
somebody is having the progression. What is your line of treatment, Dr. Sandeep?
In the combination chemo osimertinib.
Yeah, you have used this combination for this lady,
Hello.
and now not progress, but just think that she has progression, maybe after 3 years. So, what is the line of treatment you'd like to offer to her?
Yeah, at present the guideline has amivantamab lasertib, but I don't have any experience with that. We have to again go with the second line chemo.
Guidelines says so. After progression, we use this. We should use that. Which guideline?
I think again Mariposa 2, I think.
Mariposa has taken different patients, right? Not on
Yeah,
progress.
yeah. Mhm.
Mm. So, Dr. Anisha?
I would like to get a repeat NGS for this patient, and because it's the first progression, and I'd like to check for any changes in the drive and IHC also. Based on that, I would like to take a call. But all the patients who are progressed on FLORA2 regimen, I think they received chemotherapy in the trial. The post-progression outcomes are only seen in patients who had taken chemotherapy.
You'd like to do the repeat NGS to look for the any resistant mechanisms, or you're thinking that some new mutation?
Maybe some new mutation might show up because it's
Target
first
druggable.
progression. It's first progression for this patient.
So they're not revealed anything of anything significant or any druggable mutation you have found then?
Then it's chemotherapy, second line chemotherapy.
Anybody tried immunotherapy here? In this case, those who was progressed on EGFR inhibitors and chemotherapy.
I just started ABCP for a patient, so I'm waiting for the first assessment.
Okay.
Then, sir, actually, I have started the ABCP for a couple of patients, so none of them did any better. Like I think they got progressed pretty soon, like in matter of 4 to 6 months.
Can you? Yeah, these patients are like once they are a progression, so the burden of disease probably if it's the higher or can tolerate 4-drug regimen. I'm not sure, but definitely we can try 3-drug to start with. In those cases. And repeat NGS, I agree to just for the check the resistant mechanisms or meta amplification or something or anything which will help us to target again. So post progression in this trial, they have used chemotherapy, and surprisingly, those patients who have received the chemotherapy post progression, second line of chemotherapy, had a better outcome. Probably the continued response, probably one of the reasons they have explained, and those received combination did better, even PFS too, hazard ratio 0.7, and that is really welcoming, and where we can use combination upfront, the best drug first, followed by any kind of chemotherapy or immunotherapy or newer drugs coming up in the market. So in the overall analysis, survey analysis also done at second interim with 40% maturity, showing trend towards OS benefit, though the data still is immature. So we are waiting for the OS data as well, and the survival curves are also separated and maintained with plateau at the end of 39 months. And when you see at subgroup, so sorry, when you see at the subgroup, there are certain patients who who are above 65 years and who are having no CNS metastasis at baseline, did not benefit much. So the current guys still consider this as a category 1 option, and still not don't have any comparative data, cross trial comparisons to say that it is definitely better than amivantamab or lizardine combination. And we can still go use the osimertinib in those patients where they are frail and not able to take chemotherapy, and we can give a chemo-free option like osimertinib alone, or we can use mariposa drugs together. So with this, I conclude the panel discussion, and thank you so much for your expert, insightful inputs. And thank you each and everyone. Any other questions, other panels? Yeah, fine.
I just have a
Yeah.
question. I have a patient with EGFR L858R mutation, and also has MET exon 14 skipping mutation upfront. For this patient, I have discussed osimertinib plus tepotinib. Obviously, patient is unable to afford. But my question is that the right approach, or is there anything else that we can do? This is just an academic question to all the panels.
You said EGFR and MET, right?
Yeah, MET exon 14 skipping and EGFR L858R.
Okay, so why not amivantamab?
Yeah, so that is one thing. I had counseled that also to the patient.
Incidentally, I should tell you, like I also have a patient who had both the mutations in upfront, like untreated patient. They couldn't afford it, but at the time I have gone through the literature, I also thought probably this would be a good option. In fact, in the literature, I could see the instance is very less actually. In fact, the lab, they called me before releasing the report. Sir, how often see what's your literature?
So, but I feel, Rachana ma'am was pointing out that complex mutations upfront are very rare, but I think with the advent of more and more NGS and more lung cancer burden in India, we will be seeing more patients like this. Like I also saw EGFR ALK, EGFR ROS, various targetable combinations.
There are no more mutually exclusive, say.
True. Absolutely.
Okay. Yeah.
Sir, one point I would like to add. Hello.
Yeah, please go ahead.
Sir, in post osimertinib, we can see really we can see C797S mutation where there is loss of T790M loss. They can respond to second generation TKS such as afatinib and also sometimes first line TKS like gefnib. We have seen one patient.
Okay. Yeah, always something in the similar to ALK inhibitors where someone progressed on everything like LOL and alectinib. Some mutations are still sensitive to crizotinib. Something same apply, but I've not came across any kind of such patients. I've not used. Anybody has re-challenged after a certain time of platinum-free interval? Any
Rechallenge
osimertinib
platinum
re-challenge?
or
Osimertinib.
no.
Osimertinib in case of there is a mild progression or asymptomatic one or two side progression, we continued it. And re-challenge we don't have, but continuation of that drug we have seen.
Well, good evening. My question is, what are the patients where you will try to choose amivantamab plus lazertinib in the first line? Yes, we have both of the combinations are category 1. Do you have any preference to choose this combination over the FLORA2?
It is a chemotherapy-free regimen, right?
Yeah.
So someone doesn't want chemotherapy at all, and definitely we can give this option.
And also somebody who has very deep pockets.
Yeah, that is out of the question though.
Correct. So, but yeah, at a risk of thromboembolism, almost up to 30% of the cases, we need to give the prophylaxis upfront, and infusion reactions may be managed with split dose, but still we have to explain that.
Sir, have you used amivantamab?
One patient so far.
So patient has tolerated fine.
Further, Maddie is a 79-year-old doctor. He
Oh,
wants to use that. So I started him. So he's doing well after 4 cycles.
Okay, you followed
We have used one antimab.
Sorry?
For any exon 20 insertion. We have
also
used
Papillon. Okay.
Yeah.
Got it.
The patient at third cycle, he got myocarditis and expired.
So drug-related myocarditis.
Yeah, he was importing that momentum from US. This is almost 1 year back.
So you followed Cocoon or Skipper? Were they there by then, or you just?
Which one?
The prophylactic protocols that have come up recently, were they followed?
No, we are not. Those are not followed.
We had one patient with amivantamab. He had severe infusion-related reactions. Even though we gave him day -2, we have given him 8 milligram dexa BD, and day -1 also we've given him 8 milligram dexa BD, and one on the day of infusion. Despite of this, his infusion took like over 12 hours, and continuously he was having a dip in his SpO2 and raise in heart rate. He was monitored in ICU, and we have given him, but finally he was out fine.
Did you see reactions subsequently? Because they claim that it's only during the first dose.
Yes, sir. During the first infusion, the reaction was severe and the infusion time was around 12 to 14 hours. But during the second infusion, yes, as they claimed, the reaction was lesser and the patient's infusion time could be shortened to at least 6 hours, I would say.
He tolerated well?
Yeah, he tolerated the second infusion also well.
Yeah, but always with the first infusion only. So basically, the slow and split infusions probably will help us.
Even there is literature showing usage of montelukast from day -5 before infusion, along with dexa, or so.
Yeah, it has a histamine released mechanism as well for the reactions. So it definitely will help along with steroids. Yep. So if there are no further questions, so let's conclude the session. And thank you so much again, everyone, for being there. I'll just hand over the mic to.
Sorry to interrupt, sir. So I just wanted to inform that due to some personal reason, Dr. Vijendra could not participate in the event.
Okay. I'm really sorry. So Dr. Sreekanth will be talking about the SCLC management.
It's okay.
I'm
It's
really
okay.
sorry, sir. Actually, I missed
Yeah, it's
that.
okay. It's okay.
Please go
Most
ahead.
of the times, and the panel discussions
Yeah, I
is
would
at
have
the
kept
end of
your presentation before our panel.
the session, but
I just missed. Please,
meanwhile,
please, sir,
they will
please go
cover
ahead.
the first initially NSCLC followed by SCLC. That's the matter.
Yeah,
Yeah.
go ahead, sir. Go ahead.
Yeah, first of all, I would like to thank organizers and Dr. Harish for giving this opportunity. And today I would like to discuss the role of immunotherapy in limb-tested SCLC. You can move on next slide, please. Yeah, of course, everyone knows about that this slide, and lung cancer is a leading cause of cancer-related death, and SCLC out of that it represents 15% of total lung cancer malignancies histology-wise, and the median age at the time of diagnosis is 60 years, and brain mets those who are painted with the 50% of patients, and most of the times, almost always, it is associated with smoking. Next slide. This is the clinical profile, which is the study conducted in North India. It is a 12-year analysis of tertiary care center, and they are included the 361 patients over 12 years, and out of that, their limb-tested disease found to have nearly 27% of cases, and extensive disease at around 73% of cases. The median age is 57.3 years. Smoking status comes around 77.6%. Good PS, that is ECOG less than or equal to 1, that is 65% of patients. And they are management wise, they are dividing into the CCRT and the chemotherapy part, and surgery, none of them are underwent for the surgery, and CTRT nearly 24.5% of patients, and chemotherapy 69% of population received the chemotherapy. If you look at the outcome of this particular study, the median PFS is 169 days, and median OS is 191 days. Next slide. Definitely, we have a very high need of unmet need in the limited stage SCLC. Why? Because even though we have a very good response to the treatment initially with the CTRT. Next slide, please. With the CTRT, we have a very good response of treatment. Still, the majority of patients are getting relapse within the months of initial therapy. Even though some patients have long-term survival, nearly 20% of patients after CCRT, still the overall cure rate is very, very low in this limited stage SCLC. So if you look at the median OS, it is comes around 25 to 32 months. 30% of patients with limited stage were alive at 5 years. The 5 years OS is 16 to 34 months. 34%. Next slide. If you look at the thoracic recurrences at the end of 2 years, it is the cumulative incidence comes around 50%, and CNS recurrences at the end of 2 years is 19% in limited stage disease. Next slide. Coming to the classification of SCLC, and for the NSCLC, next slide, please. For the NSCLC, we are using the TNM classification, and for the SCLC, we are using the veteran lung staging system, and we have to divide into the limited stage disease and extensive disease. So the disease is confined to the one hemithorax, which includes the regional node metastasis, pleural effusion on the same side. So particularly those who are confined to area that are that are incorporated within a single radiation port, with corresponding to the TNM stage, it corresponds to the stage 1 to stage 3B, and limited stage patients are nearly comes around 33% of presentation. And with the extensive disease, tumor beyond the boundaries of limited disease, which includes the distant metastasis, malignant pericardial effusion and pleural effusions, and contralateral lymph nodes, that is supraclavicular and contralateral hilar lymph nodes. Nearly two-thirds of cases are presentation with the extensive disease. Next slide, please. If you look at the disease classification and treatment options, and in the limited stage, we have an option of surgery, and followed by chemotherapy and thoracic irradiation, CCRT. On the other side, those who are receiving the chemotherapy with the platin and detoxide, and followed by thoracic irradiation. In the extensive stage, we have an option of well-established role of immunotherapy in the extensive stage disease with the chemotherapy, and we need to give the maximum of 4 to 6 cycles, and followed by immunomaintenance. And those who are contraindicated for immunotherapy, we need to give the chemotherapy alone, followed by prophylactic renal irradiation. Next slide, please. If you look at the current landscape of treatment and patient approach of the small cell lung cancer, next slide. These are the concurrent CCRT in the lip tested disease, and most of the times we are giving the cisplatin and etoposide along with the radiotherapy is the preferred option. Those who are in the good performance status, and those who are poor PS, and we can consider the sequential chemoradiation. And surgery followed by adjuvant chemotherapy or concurrent CCRT is the preferable, those who are eligible patients, but as a clinical part of those are very, very small in numbers, and currently there is no approved target therapy or immunotherapy in limited stage disease. Next slide. Coming to the CCRT treatment regimens, we are all very well aware of platinum and etoposide regimens, and along with radiation, and it should be started after first cycle or second cycle of chemotherapy, and all these are the protocols which we are regularly following. The standard radiotherapy regimen is 45 gray twice a daily for 30 fractions, but it is not practically, it is not possible, and we are giving once daily dose. Nearly 66 gray comes around daily dose, and CCRT is preferred over sequential therapy in those who are in good PS and those who are in poor PS, and sequential chemoradiation is the option. Next slide. Coming to the PCI, and more than 50% of risk of brain metastasis in SCLC, PCI we can prevent this, and this is recommended in the limited stage disease, those who are having a good response, good PS, and age less than 60 years according to US protocols, and less than 70 years according to the Europe protocols. And PCI use depend on the clinical factors and patient preferences and risk of neurotoxicity. It improves the 3 years OS by 5.4%, and it will decrease the brain metastasis risk by 50%. And nowadays we have an option of MRI surveillance versus PCI, and nowadays we are regularly putting on the patient on MRI surveillance, those who have a good response without any CNS involvement. Definitely we have a good option of MRI surveillance in that particular setting. Next slide. Coming to the immunotherapy in small cell lung cancer. Next slide, please. Starting with extensive stage, and we are as a practical and clinically we are regularly using the chemo along with durva or atezolizumab, and those who are contraindicated for immuno, and we are giving the chemotherapy alone. And according to the NCCN guidelines, the refractory or sensitive disease is NCCN. According to NCCN, it is 6 months they are taking as a cutoff. For the ESMO guidelines, it is 3 months. Those who are sensitive disease, those who are progressed after 3 months, definitely we would like to re-challenge the platinum chemotherapy. In the refractory setting, we have an option of topotecan and lurbinectedin and supportive care, best supportive care, depending on the performance status. Next slide. Coming to the role of durvalumab in limited stage SCLC. We have a trial that is called as Adriatic trial. This is the phase 3 trial, and which include the stage 1 to stage 3 limited stage SCLC, and those patients who are having a good PS and had not progressed following CCRT, and PCI permitted before randomization, and they randomized into the 1:1 randomization, durvalumab versus placebo. The primary endpoints are OS and PFS. Next slide. Almost all baseline characteristics are across both groups are equally divided, and the majority of patients are receiving the cisplatin, and the majority of receiving the once daily radiation therapy. 53% of patients received PCI in the trial in both arms. Next slide. If you look at the overall survival at the end of 2 years, the 2 years OS rate is 68%. At the end of 3 years OS rate is 56.5%. If you look at the median OS in terms of months, and with the durvalumab it is 55.9 months, and with the placebo it is 33.4 months, with a hazard ratio of 0.73 with a significant p-value. And this is the first and only immunotherapy which shows the median OS benefit and 3 years OS rate of 56.5%. Next slide. The benefit was the overall OS benefit was which was consistent across all subgroups in the baseline characteristics. Next slide. Coming to the PFS, and if you look at the median PFS, it is 16.6 months versus 9.2 months. At the end of 2 years, the PFS rate is 46.2% versus 34.2%. Next slide. This is also PFS is also showing the benefit in the across all subgroups. Next slide. And coming to the benefit of PSI and PCI in the limited stage SCLC, still it is not clear why, because initially in the meta-analysis they are included the 28 studies. In the out of all studies, the benefit is favorable for the PCI in this limited stage setting. They are observing the significant beneficial effect in terms of OS, PFS, and incidence of brain metastasis. And this meta-analysis have several limitations. There is lack of randomized studies, and these are almost inclusion of small studies, and there is a heterogeneous follow-up of brain MRIs. Next slide. We don't have any direct evidence from the RCTs as of now regarding the PCI in the limited stage disease. These are the trials which are we need to wait for that results for the whether it is benefit of PCI is there or not in the limited stage disease. Next slide. Coming to the prior PCI, whether we are observing the OS benefit irrespective of whether the patient is received the prior PCI or not. And if you look at the PCI, those who are receiving initially at the front, the median OS is not reached till now, and with the placebo it is 42.5 months. If you look at the those who are not received the PCI, the median OS is 37.3 months versus 24.1 months. Next slide. Compared to the OS, it is same as PFS also, and there is a irrespective of whether the PCI is given the prior or not, and the benefit of PSI is observed in both the groups. And with the PCI, the median PFS is 28.2 months versus 13 months, and without PCI, the median PFS is 9.1 months versus 7.4 months. Next slide. These are the adverse events which we are observing with the durvalumab immunotherapy, and radiation pneumonitis is the most common adverse events which we are observing with the immuno. That is 29.9% of patients are developing the radiation pneumonitis, and most of the adverse events are grade 1 and grade 2. And with the immuno, grade 3 events are observed with radiation pneumonitis and diarrhea, pneumonia, and pneumonitis. These are the 4 events which we are more than or equal to grade 3 events which we are observing with the durvalumab. Next slide. Coming to the conclusion, and this is the first and only approved immunotherapy in limited stage SCLC, which the treatment of limited stage disease is always curative intent. In spite of very good response with the CCRTs, the long-term outcomes are very, very poor even though it is limited stage disease. CCRT is the gold standard and currently standard of care for treatment of limited stage disease. The immunotherapy, that is durvalumab, as consolidation therapy after CCRT, demonstrated a significantly and clinically meaningful improvement in OS and PFS as compared with placebo, and these are the median OS of 55.9 months versus 33.4 months, and median PFS of 16.6 months versus 9.2 months. And as a durvalumab consolidation is most of the times it is very well tolerated up to 2 years, and the safety findings were consistent with the known safety profile of durvalumab monotherapy in the post CCRT setting. And with this, I would like to stop here, and thank you again.
Yeah. Thank you, Dr. Sreekanth, for the brief review. So with this trial, can you skip the PCI in a limited stage?
Yeah, in the limited stage, definitely with the availability of immunotherapy, and we have to go with the MRI surveillance rather than that is we have to frequently we need to observe the MRI rather than if we are skipping the PCI. Definitely we need to counsel the patient as a we need to educate the patient regarding the symptoms and signs, and we need to counsel the patient regarding frequent surveillance of MRI. That's the thing, and I think for that patients, those who are having a very, very good response in the limited stage setting, and with the maintenance of durvalumab, we can skip the PCI. Definitely, we can skip the PCI.
Okay. Thank you, Dr. Simha.
Yeah, thank you, Harish.
So,
I just have a small question. So in this trial, Adriatic, how many percentage of patients received immunotherapy subsequently also? Is there any data on that which is published?
after
Once after progression to extensive stage, because we know that immunotherapy is the only thing which we have to add to chemo once it is
Yes,
extensive stage.
Yeah. And post progression in the limited stage patients are progressed on to extensive stage after immuno. Is
Correct.
it right?
Correct.
And I don't know, and I need to go back and
Okay.
study the trial and.
Okay.
Yeah.
And also, I was curious to know about the crossover. Like, how many patients crossed over from the control to? I'll go through
During the treatment also they have
Yeah.
to the progression patients, right?
Correct. If they did not allow crossover, obviously it would have its
Yeah,
impact on that.
definitely. Yes.
Okay, so if there are no further questions, let's conclude here. And thanks again, everyone, for being part of the program and giving their insights. And we all know that the debate is not going to end where with the advent of so many drugs in the pipeline, the new upfront first standard of care will be changing every year. So we have to keep up the data. At the same time, we have to check with our population. We have to personalize the therapy for our patients. So with this, I conclude the session. So thanks you everyone, and good night. Thank you.